Thank you all for the very insightful perspectives and sharing your experiences. I'll start first with a question about evaluation and feedback or assessments of the different methods that you've described. So I know there is some data, not a lot, but if you have any data on what's working well with how you're communicating research results, as well as what's not working well, that can help inform sort of the next steps or things that can be scaled up or scaled down. And Sara, no pressure to start with you, but want to make sure you chime in case we are going too fast. So any thoughts on evaluations or data around how we evaluate what's available? What do we know about what's working well?
Well, I can just comment. I'd like to make two comments here. One, in terms of evaluation, I really think it needs to be a staged process. I think before the study is even undertaken, as I said earlier, I think there needs to be a solid communication plan in place. And I think it has to be pilot tested in some way with representative, a small set of representative participants. Because as indicated by my colleagues, needs of participants vary not only in terms of how information should be presented, but also in terms of the types of information that they want. I think that for the most part, and then receiving feedback after the study is completed is, of course, another part of the evaluation process. And I think that generally, as far as possible, a personalized approach is preferred, but that, of course, depends on the resources available. And how that personalized approach, of course, plays out varies according to the nature of the study and the nature of the results and the user group.
Thank you.
I'm going to talk a little bit about not necessarily work we've done, but work we're doing. I think, as I described, we just recently launched starting to have participants provide biospecimens. This is a pilot phase. There had been no intention, and we've been very clear that we wouldn't be sharing any biological results as a result of this early phase, that we wanted to engage participants to be learning with us as we went along. So the whole process has been a learning experience, and the whole process has been evaluated every step along the way as we go. But one of the things that we're continually asking the participants is to understand, if we were giving you something back, what would be the kinds of questions you would have, and then begin to evaluate within the scope of the research project, can we answer that question? What would that question actually need us to do in order to be able to get to it? What's the risk associated with answering that question with that? And then being able to give that back again to the participants to say, here's what our evaluation of what you would like to learn has resulted in as we've looked at the legal and the other kinds of regulatory requirements we'd have to meet. Plus, we also want to understand how it would feel for you if you receive some of this information. So we're really trying to engage them as much as possible in this very early pilot phase to better understand. And so we have hundreds of people who are now starting to do that across 4 different very serious conditions. And so we have some generic kinds of things they're interested in learning about, some condition-specific things that, if I have this particular type of condition, what might I expect some of my results to look like? And then the personalized factoids we're talking about, if I have this, what will happen to me? The other thing that we actually have been doing across our ethnographies over the last 7 or 8 years, we've learned that there's probably about 6 common questions most patients have. And what we're trying to do is figure out, can those questions align with the kind of information that we might be gathering now from a biological sample? And I'll just quickly read those questions. And these have come from a distillation of a patient-caregiver journey framework we've created over the years, and have revealed the kinds of common things that people want to know. So if we can't answer some of these questions with some of the return of results that we're starting to think about doing, then we wonder whether or not we have either the right set of questions now with this new source of data, do we need new questions, Or did whatever we're trying to return maybe not make sense in terms of the ways that patients typically think about this? So one of the things is, what is this thing that I have? They want to better understand whatever this condition is that they have. And we're talking about people who are living with illness. What might help me live with it? So I think that's to the point that we talked about yesterday. It wasn't necessarily how will you cure it. It was really more, what do I need to know about living with this, and how will that change over time? And is there anything from these specimens that will help me better understand that? Am I crazy or alone? That's probably the most common question people ask. So being able to aggregate some of these insights would probably be helpful for people. How do I deal with the problems caused by whatever it is that's going to be identified? What will this do to me in terms of my ability to pay for my care, the work I need to do in terms of being employed or being a parent? And then what's going to help me live with it? So I think, again, it's really, from our perspective, we're trying to evaluate at every step along the way from the participant's perspective. If these are the important questions and we have some very specific kinds of information we might be able to return, how do we do that in a way that's actually responsible to help you get the answers to those important questions? So I'll stop there. But it's just one way that we're trying to proactively, while we're doing it, building the plane while we're flying it somewhat, to better understand what the experience is like for people who are actually in this study with us right now.
So we have started to evaluate the experience of returning results from genomic studies, and this is actually something many people have started to evaluate, and primarily my knowledge from this comes from participation in the Seizure Consortium and the Genetic Counseling Working Group. The modes of returning results that we've evaluated, though, have primarily been traditional modes, and so these alternative methods that we've been exploring here this morning, we have not yet evaluated them, and so I think there's a lot of work to be done. I think there is some literature out there in terms of the carrier companies that I spoke about, or direct-to-consumer companies that have tried to evaluate their experiences. In general, in the traditional method, people are doing very well. These individuals are incredibly resilient, maybe because of why they have come to genetics and when they're having diagnostic genetic research or research that is leading to diagnoses. They have had experience with genetics usually prior to even coming to it. They then receive results through a very traditional method. And when we evaluate things like anxiety, depression, distress, positive or negative experiences, these are things that, there's some measure or levels that kind of rise immediately after results are disclosed in some cases, depending on the results, but oftentimes normalize after a period of time. And it's similar to what we've seen in the literature when looking at just in general returning genetic results. And so I think there's still a lot of work to understand kind of, can we create different modes of delivery, and what is this experience going to be like for participants? And then I think again, the participants that we've returned have been a very select group of individuals who have existing knowledge and existing experience that people won't have as we move forward.
Yeah, I just wanted to echo to Julia's comments. I'm going to keep doing that as long as they make me go after you. Hope I can go in front of you because you keep saying things I want to say. I assume the committee is aware of Leela Jamal's paper, on which Amy McGuire is the last author, on blurring bins in returning results. I think that's the best paper that's come out in the last year or so on this topic from an evaluation perspective. Similarly, like to Sally's point, we haven't started returning results to people on genetic results at Sage. We're in the process of doing the work. What we do know from some of our non-genomic data return is that people use the data in ways that we didn't expect necessarily. We have a Parkinson's study where we give people back their dyskinesia and their gait data, and we're hearing things like yoga studios that offer yoga for people with neuromuscular diseases have started having everyone use the study apps that they can come in and show each other if they got better or worse over the last week. This is not a way that we intended for them to use their data return, but it's something that they're doing with the data return process that we created that's deeply engaging and important for them. And I think that's one thing to expect, is that people will start using these returns in ways that you didn't expect, for good and for bad. And so we tend to focus on the bad side of that a lot of the time, but sometimes it's kind of neat when people come back and they say, this is why the data return is important to me, is that it lets me compare how I'm doing to other people. It lets me go to my doctor and get more autonomy or mastery over my care plan. So we're seeing that. What we're seeing in the design process for precision medicine is more to the point about early adopters shouldn't drive all of your design and planning. Early adopters tend to be very sort of fault tolerant and very aggressive and very motivated and very informed. As this starts to scale, we can't assume that those traits will scale out. And again, in design, you think about personas. You don't assume everyone's going to be the same and create a single process. And so we're working mentally with a model that there's probably, and you have to have some sort of way to plot people, right? So you say, maybe there's a grid in which one axis is openness to research to skepticism of research, and the other axis is capacity to engage in the information process. And so we've mainly been engaging with people who have high capacity to engage in the information process, and we're very positive about research for the most part, especially people with rare genetic diseases. As we get people who may be more skeptical of the research enterprise for justified reasons, or because of time, money, socioeconomic status, literacy, what have you, have a low capacity to engage in the information space, we need to start thinking about different ways that we offer results returns, different levels of support for different kinds of personas, and assuming that we may need to offer entirely different processes and interactions for people who fall into different parts of that grid. Because one of the biggest dangers in tech, if you will, is assuming that the early adopter who buys the first version of the watch is the person who's going to be buying the watch in year 2, year 3, year 4. That's one of the things that kills a lot of modern technology products. And if we take that approach here, we wind up running the risk of missing significant cultural, social, economic differences in the way people think about their genetics, the risks that they believe exist, the benefits that they're willing to see or even able to see. And so that's the main point I would take out of this is that any analysis of the efficacy is missing because we don't have scale. We have in the low thousands of people that we use to study on this, as opposed to the millions of people that we're going to need to make meaningful statements about diverse demographics and how they deal with results return.
Thank you. So if I got it right, I think we're going Deborah, Greg, Vanessa, Chester, and Sue.
So how scalable are the different approaches that you're using? So I would imagine that John Sage Bionetworks is fairly scalable since it's more web interfaced, and you spoke about having office hours where anyone can call in, so it's not the individual approach that Julia, you're talking about doing, and Sally, I guess yours is scalable also because it's web-based. And I forget the person on the, Sara, I don't know how scalable your approaches are. So maybe you could talk about, how, if everyone had to return results who was doing research, are your systems adaptable?
I think that's your cue to go first, John.
The honest answer is I don't know. We're trying to scale specific projects that we're involved in, not to create generic scalable systems. And we're still designing them, but that's certainly the hope. There tends to be two sort of philosophies to scale. One is to automate everything. We don't tend to take that approach. We try to amplify human expertise because we think that's a more plausible way to do it, at least in the next 36 months or so. But we're going to learn a lot about how well that works. And so when we think about office hours, for example, we have hypotheses about how that will work. But we also believe that we have to, in tandem, run a series of evaluation methods. And so we know from our consent work, and for disclosure, like Consuelo is evaluating our consent work, for example, using cognitive interviews at the moment. We have a mixed methods analysis going on of our consent work with one of the other awardees inside PMI. We have an RCT going to demonstrate equivalency of our consent work at Geisinger. And so the hope is that in the same way as we begin to look at some of these more scalable methods, that we can actually test them, because the gold standard is what Julia talked about. And we have to hold ourselves to that standard as we start talking about scale and not get fuzzy and say, well, it's okay to trade off tons of effectiveness for scale. But the hope is that scale is something that we can achieve while we start talking about longer term solutions like, genetic counseling assistants who can help you with things. I think that's probably the long-term scale, is more human expertise that can be amplified through technology. I would be very, very nervous of, AI systems that promise to answer all of this stuff through contextual conversation. But if we can use the technology to amplify, then I think we have at least a shot. But I don't know what that means for an organization or a research institution that doesn't have the human expertise to amplify in the first place.
And are you targeting only participants, not healthcare providers, who will have research participants appear with these things, this information? Are you doing anything to help healthcare providers?
My organization isn't specifically. That is happening inside the projects that we're involved in, but we're not sort of on the line for that. But when we design things for the participants, we design it with the idea that, again, they will carry that return into areas that we might not expect. So we do expect to provide that in a format that we would say, if you want to go to your healthcare provider, this is the format that you should take, as opposed to if you want to go to PatientsLikeMe or 23andMe and syndicate your data there, this is the format that you should take. So we take more of a format approach to reformatting the same information, and we'll probably provide that in 2 or 3 different vectors, one of which is a provider look, one of it which is sort of a very technocratic API look for you to take it to companies.
Else?
I'd like to make one comment. I think we have to be careful. I think obviously technology offers a solution for making communication more scalable, and another aspect of technology is that it does allow for flexibility, and easier flexibility to some extent in formatting of information. But I think we have to be very careful when we think about using that broadly, because even in this day and age, there are people still who do not have access to technology systems, especially when we're talking about people in the lower socioeconomic strata, people in the older cohorts, and people in rural locations. I mean, our experience currently, and when we've done work with caregivers, even in family caregivers of dementia patients, even in some of our urban areas in Miami, many of them still lack access to the internet, and sometimes the neighborhoods that do have access, it is not as strong as one would want. So we need to think cautiously, and there I'm only talking about access to the hardware, the internet, etc. But we also, many people still lack the proficiency to successfully use technology in a meaningful way. So I think that's a question that we need to think about, and to some extent that's, I think, a policy issue as well.
I would just echo again what Sara was saying by phone. I think, so one of the models that we're using right now are not scalable, but we're investigating models that potentially will be more scalable. But in this, we're also trying to recruit a more diverse population into it. And for the populations who are, as Sara was alluding to, when we recruit an individual who is maybe a first-generation immigrant, an older individual, Spanish-speaking, they want to come in and have a 20-minute discussion with you about the study. And we as genetic counselors love that. We do want to have a 20-minute discussion with you about the study, but that's not scalable. And I anticipate these same individuals, regardless of their results, will also want to come in and have a discussion with you about their results. And so we just need to be conscious of that. I also would say that as availability to technology expands, people might not have access to a computer or the internet, but they might have access to their phone and the phone line that they have. And so making sure that when we make things in alternative delivery methods, that they're it's something that works on your little 3-inch screen and not necessarily you need a 13-inch screen in order to use it. And then just being conscious of how people are comfortable receiving health information. I think, someone in their 20s is very comfortable getting all of their results through some type of portal, but someone else might not feel comfortable, and that's not the way they receive their results. And so in order to really make this something that works for everybody, we need to think of all of these different preferences.
Since Sara mentioned policy and Julia mentioned working with assistants, as the committee think back to physical therapy, occupational therapy in the 1990s, right? The creation of OTAs and PTAs as a way to deal with the low capacity of physical therapy and occupational therapy in the 90s, right? Medicare, CMS started reimbursing PTAs and OTAs for the work that they did, and that actually led to a pretty significant boom in the capacity of those occupations. And so thinking about something like that as a policy recommendation, there's precedent and it worked. So they just want to make sure that we're flagged now.
And the last thing, I did bring this up yesterday, but it would be something I think we need to think about in scaling, and that is peer-to-peer power. And we've demonstrated that for many years, and I think there's opportunities to be able to give that kind of training and understanding of the kind of experience that someone's already had, getting information back and being able to share that with someone else who's getting ready to get information back could also be quite scalable and powerful.
So this is maybe for John and for Sally. This conversation that freaked me out a little bit because I don't work in genetics, so I didn't know these groups existed before. So you're a data broker. You sell my data. If I give my data, it's citizen science, but it's also who enjoys the fruits of what happens in either of your organizations in terms of patents or commercial development of new drugs or devices. I'm giving my data to you. You have the data, rather than me holding the data in a blockchain or some other secure system that I own my data. So I need to know about this ownership issue, because this is not about education anymore. You're providing a service to me. I can talk to my friends. I can get some information. But in the end, you're taking my personal data and using it for commercial use. If it's not true, help me, educate me. But it's a little bit.
We're a nonprofit, so none of that happens with us. We have no patents. We're an open science organization.
So who owns my data?
You own your copy of your data, but you can't own data the way you own an Apple, right? If data gets copied, your rights cannot attach to other people's copies. So if you put your data into a clinical research study, right, we give you a copy of your data back, which is yours. You can do whatever you want with it. There's one copy that goes into the study, which is governed by the protocol, right, that you consented to. And then if you choose to make an open donation of a third copy of your data for the public domain, you can do that, but that's your call. And that's all we do.
So we are a for-profit organization, and that was an intentional decision made when we first established Patients Like Me in 2004. The notion being that we wanted to create value from patient-generated data, that was the important part of what we were trying to do, and then be able to bring that into the ecosystem of pharma and academic institutions and others that weren't collecting this data in a methodologically rigorous way, as we are. So the idea is that there's no charge to patients to participate on the site. There's no advertising on the site. So the only way that we can actually have a business model is to aggregate that data in meaningful ways and establish ways where we have already created a trust relationship with the patients, that we're going to use those data to answer questions that matter to them and ultimately give them back information that will be useful in their daily lives. And that's really the social contract we have with the patients on that. However, at the end of the day, they still own their data. We see ourselves as data stewards of that data, and our responsibility is to do something meaningful with it and then give that back to them. Now, where we then have a business model that helps us do that is to establish that as a value back to whomever is interested in getting access to that kind of data. As we move into the space of the biospecimens being a part of the whole picture of that patient, ultimately our goal is to have a digitized version of that person. That's part of why we're in this Digital Health Alliance. And ultimately, again, that person would be the owner of that digitized version of them, and that their opportunity to participate in what we're working on would be giving access to others that would have interest in taking some of that aggregate data and making some sense of that that for drug development or other sorts of kinds of health products that could be created out of it. But ultimately, it is your data. You've given us the opportunity to be the steward of it, to do something with it that ultimately could give you something back at the end of the day that would be useful for you in your management of your condition or in your daily life. So that's the way we have focused on that. So the ultimate owner of the data looks to us to be trusted stewards of that data to ultimately find some useful, meaningful way of using that data.
But I want to push back on the whole use of the word ownership, right? Because especially when it comes down to your genomic data, right? Anyone who's got any biosample of you can regenerate a sequence from that biosample, and you can't exclude them from that, right? So the idea of ownership to an average user includes the concept of exclusion. Right? And it is almost impossible to do exclusion-based ownership and control with data, especially data that can be regenerated at an increasingly low cost by anybody who has access to a sample. And so framing this as a property right, in my opinion, is a failed plan from the beginning, because it creates expectations that cannot be fulfilled over time. As opposed to saying for any given sample, there exists potentially, right, a digital sequence that can be extracted from that. The digital sequence, once copied, is again very hard to control and own. And it gets down to, right, from a policy or a legal perspective, what are people allowed to do with it? And what are they allowed to exclude you from doing, and vice versa? But framing this in the way that most people think about a physical object like my phone, right, or this cup of coffee or an apple, I think it creates expectations that are almost guaranteed to fail. So it's about who has rights to a copy, what rights do they have with that copy, can they exclude you from doing things with your copy? That's a more realistic way to frame the issue until there's like a significant policy change, probably a congressional legislative change.
Vanessa?
I have two questions, and one has been dealt with tangentially, and that is working with diverse populations. There are national standards, the class standards for culturally and linguistically appropriate services, and I've not heard much conversation on working with different populations, your experiences, what's worked. I mean, that, we've heard a lot, well, we might need genetic counselors, but whether we need, who are the genetic counselors? Do they have the skills to work with diverse populations? So I'd like to hear more about that, your experiences with that, what needs to be done. Because one of the things that's come out of these past two meetings is that there are diverse groups of patients and people we're working with. So I'd like to hear much more conversation about communicating with those groups. Then the other is more a public education in talking with communities about return of results, because there's almost this assumption that people know about this. And that when you work with some of the communities I work with, and to paraphrase you, Sally, you say give something, get something. But I work with communities whose experiences have been give something, get nothing. And so I'd like to hear more conversation about this, and especially in terms of how do we communicate this. Thanks.
I wonder, for the first question, if we start with Sara and Julia around communicating linguistically appropriate information, culturally, yes, class, certainly. Sara?
Sure. Yeah, sure. I think this is a big issue, and what we have learned, because Miami has a very diverse culture, is that it goes beyond language. It goes well beyond translation. It is also how information is delivered and who is delivering the information that's important. And I think that most of the work maybe in our area has been done with Hispanic populations, and I think one has to be careful there because there are subpopulations of Hispanic code, so we can't just say, oh, this person is Hispanic, because the Cuban Hispanic is very different from someone from Central America, and we can't just lump people as minorities in the same vein, because African Americans have very different culture than do Hispanic populations. The other comment I want to make is we need to have a broader umbrella. One group that we work with are Haitians, and that is very different in terms of how information is presented. In the first place, it's difficult sometimes to translate things into Creole. That's something that we have struggled with, and we've worked with people from the actual Haitian community to help us with that. And also, many of the Haitians, at least in our populations, do not read. So we have to present information in auditory or using other formats. And I think that something I'd like to stress is and this has been brought up earlier, but it is in the bringing in the involvement of participants and of the community early on in the development of a communication plan to understand what their needs are, what their preferences are, and to think very broadly about user groups and how they vary. And one important characteristic besides things like age, functional status, SES status, etc., is cultural and ethnic background. So I agree with you. It is something that needs to be underscored when we're having these conversations.
Yes, and I would just also agree that this is a tremendous challenge, and I don't have any, I'm not here with an answer. I will say that cultural competency is a really big part of training as a genetic counselor and being a genetic counselor. I think this is something that we are conscious with kind of every time we have an interaction with a patient, regardless of whether or not we think that patient looks like us or similar to us or is a culture that we understand. And similarly, we are working as an organization to expand the ethnicities and culture and diversity within the people who take this on as a profession, and that has been a big challenge, and it's certainly not a short-term solution, but it's something that really does need to be addressed among genetic counselors, and it's being addressed by going into high schools and going into organizations that are created for minorities and educating them about this as a career opportunity. I think just speaking in terms of kind of what we've experienced as we try to make a model that will work or make models that work in different cultures, it's been a tremendous challenge. It's been time-consuming. It's been expensive. It's obviously something we need to do, but I do want to emphasize it's been difficult. So it's, as people have said, this is not as simple as translating it into another language. For example, we use a metaphor of a cookie recipe and altering that cookie recipe to indicate a genetic variant that is somewhat disease-causing. And we went to our Hispanic community Hispanic outreach organization within our hospital, and they said a cookie recipe isn't just going to work. And for some individuals, a recipe in of itself is not going to work. This isn't something that these communities work with. And so it's not going to be a simple translation. It's not going to be as simple as getting someone who speaks their language, and we've heard that already.
I think, for most people, you're obviously aware that the online environment typically doesn't draw in the types of communities that you're referring to, and we know that, so that we understand that our population is skewed female, probably more highly educated, we know more affluent. But we also know that there's opportunities for us to reach out into those communities in ways that we need to get proactive about. So what we've done in many of our studies, as well as what we're doing currently, is we engage a lot with the University of Maryland. We have a very nice relationship with them through a number of other projects. And so they're providing us access to communities within the Baltimore, Maryland area, where we actually go down on site and we try to learn from them the kinds of things that we wouldn't be gathering on our site typically. So that's a responsibility we've taken on. It's still a very slow go, but it's an opportunity for us to learn. Our site is only in English for that very reason. We do not believe that we can take what we do and translate it into different languages and have that be meaningful. We feel that we need to do that as boots on the ground in whatever community or country that decides they'd like to take that on with us. But we have made some real inroads in understanding the kinds of things that we might want to do, and so sometimes we don't have those members, participants as part of the membership of Patients Like Me, because that's not something they they want, but they're still participating in a study with us. So we begin to understand how we can integrate some of that into it. So.
Yeah, and it's a great point. And this gets back to starting from the very beginning in the design process to make sure that you get this right. So I was on the IRB for the Precision Medicine Initiative before we got awarded, and we had debates about what's the demographic composition of the design interview teams, right? Showing up culturally with a clipboard to ask questions in some communities doesn't indicate to people that you're there to help, right? And so there are all these implicit structural ways that you can bias the outcomes of the information you collect if you don't engage diverse groups to collect the information that are culturally relevant. Consuelo and I had to deal with a fair amount of Spanish issues last summer, just around which kind of Spanish and how you're going to frame it, right? So to me, again, I don't have a generalizable answer. I can tell you from the studies I've been involved in, it's about inclusion at every level of the governance and design process, and diversity at every level of the governance and design process. It keeps you from making howlingly stupid mistakes. And generally, it leads to better outcomes. And so, I started my comments talking about design, heuristics, adaptations. One of the heuristics we have is that we don't assume that any content we create is going to be on an electronic screen, right? The screen may well be a paper screen. And so the methods that you come up with need to be generalizable, whatever the display technology is, even if that display technology is paper. And the navigator assistance has to be usable, whether it's automated, navigatable, or you actually have a community navigator who's helping someone. And so thinking through these things and saying, is this a wizard that answers questions on a phone? Is this someone at a call center who's answering questions when someone calls in? Or is this a community representative at church or at a potluck who has read those materials and can act as a navigator? And so you have to try to build these materials to be multi-scale and not to have significant dependencies on the technology. And if you can try to do that and have effective inclusion and diversity at the governance and design levels, then that's the heuristic that seems to facilitate adaptation the best that we have found. Part of the Precision Medicine Initiative core value is that 70% of the million enrollees are intended to be those traditionally underrepresented in biomedical research. So we're going to learn an enormous amount about whether this works or not through that, and we have a commitment to publishing and sharing all of that. And I'll finish with saying that we've just started having conversations with tribal nations, which is yet another layer of complexity, history, and trust. And again, you can't say that there is one process for the tribal nations because those are sovereign nations that have had very varying experiences with genetic profiling in particular. So my hope is that through PMI we can learn some things that we can publish and generalize about what works and what doesn't work. And if we can, because it's a federal project, if we can open source that and make it as generalizable tools, knowledge as possible, that can start to create a floor, if nothing else.
And do we get to, I feel like we answered some of question two. Do you need more on that?
It's more in terms of, I think you've answered most of it, but just in terms of, have you had any experience in public education of talking to people about what does it mean for, return of results?
I'll take a quick step, again, keeping in mind that ours is an online environment, but one of the things that we have always thought about with Patients Like Me is that it is a community, so that the community itself has got to have some identity and socialization. So it's been a social experiment in building communities, and those communities have been largely built around conditions, and so people would align themselves like each other around that condition. Now that might represent some diversity within that, and oftentimes it does, depending on the condition. But there's also different ways of identifying other likeness about who you are and who you're looking for. So whether it might be either veteran interests or other kinds of interests that they have. So the one thing that we did build as part of our infrastructure is a community engagement team. So we actually have staff, one of our largest staffs actually, and every condition in our system has a community moderator attached to it, and they are engaged and embedded in that community all the time. And so there's an opportunity to socialize and embed kinds of different ideas and different kinds of conversations, but also where there might be a small number in that community, they can also try to engage them in conversation so it doesn't feel so quiet there. We've also taken that on the road, so we've taken it offline, and we're actually going out into communities where we'll have meetups with people to really kind of get a sense of who are you and get face to face. And so we're experimenting with different ways on building community strategies, but I think we've got a nice model of recognizing that you can't. The model is that there needs to be a sort of an attention to some likeness, something that we are like each other, and we have some reasons to want to engage with each other, and then allow the social experiment to start to take hold, and not try to prescribe it too much. And that's where we've, I think, excelled.
We have gone out into our community and given some presentations just on genomics and health and the relationship there, and then have at the end of that invited individuals, if they want to enroll in research studies where they can learn about this information. In those settings, it's been again, it's been working with our colleagues who are engaging our Washington Heights community in New York, which is largely a Dominican Republic population. Those have been advertised through forums where it's a health learning center, and so it's still a select population that is attending an event for a health learning center. So it's not. I think we need to do more work to kind of engage community leaders that are not potentially in the health realm. But those sessions were, I think, really informative in that people had very particular and individual thoughts about what they would like to learn from what you're doing and kind of what research they would like to see being done. And as I was saying in kind of my introductory, is that they're often individual specific, not necessarily cultural specific, how they want you to manage their information and some of the issues surrounding privacy and protection of their information is certainly things that are brought up. The understanding of GINA is incredibly low in healthcare providers and in research participants, and even after educating them about this, it's still an abstract concept, which I think just lends itself to understanding kind of where and how people are coming to all this information. We also did an outreach event with a younger crowd in our yeshiva university, so different things come from a Reformed Orthodox population and kind of the questions that come out of that. Again, questions about privacy and how this information is disclosed. So certainly we are on the pathway of learning, but I think we're still, early in that path.
Chester?
Yes, related questions. And so, one of the things I think that has come up repeatedly in some of our discussions is the potential for creating greater disparities with return of results because of differential access to that kind of information. And so I was just wondering, in your different strata, if you will, you have, high-tech and kind of more conventional approaches to this. And I think, Julie, you kind of alluded to this, kind of the process, or are you thinking about taking advantage of some of the tools that you have to really get at this question and to see, as we roll out different things and different approaches, are we in fact creating greater disparities in the process? This would be number one. And the other, just in general, these approaches that you are discussing now, systematically evaluating the outcomes of the interventions that you're employing. So that's the first question. And then I have one for you, John, that's pretty straightforward.
Anyone want to jump in?
I'll go quickly since I'm talking a lot and you have a separate question. So epistemic inequality is pretty clearly what's going to happen in this space if there's not an explicit attempt to remedy it from the beginning, in my opinion. Because what we'll do is we'll build a system for the early adopters and those with enormous capacity. And then when people who don't have that capacity arrive, we will label them edge cases and say it's too expensive to deal with it, because that's pretty much how technology does things, right? So I think that the only answer is to design from the very beginning, from the assumption that you have to have different processes for different people, and that part of the goal is remedying disparity from the very beginning. And then piece two is that I think we have to evaluate this stuff as we go. We have to be honest about whether or not things work from the beginning. And so, we've built this into our own systems that we don't do research with an agenda like in a traditional academic context, but anytime that we create something, as soon as it's possible to study its efficacy and its equivalency, we do so, and we do so in different methods. So as I said, just for our consent work, we have we've done one formative mixed methods analysis. We have a second one underway. We have the cognitive interviews going on at Vanderbilt, and we have an RCT to demonstrate clinical equivalence to a standard human consent interaction. And we're going to be doing the exact same thing for all of our results returns and publishing as we go.
I'll just add, I think, because again, as I've said, I think we've recognized our limitation in terms of being sure that we can reach the broader population. And in recognizing that, one of the things, again, when we build communities, we create an engagement strategy around that. So, for example, we were working in the development of a lupus community a couple of years ago, and what we do again is sort of that ethnographic deep dive. What is this condition? Who does is going to be disproportionately seen in, and we know it's African American women will be a large population for that group. So we try to learn as much as possible from the persona perspective about who is it that we need to be starting to get out there and start to engage and reach. And so the engagement strategy that goes into any community development is geared around how will we reach groups that we don't normally get to because they don't normally find us, and what will be the strategy to do that. And so sometimes we have to outsource some of that. We have to go out to some groups that we don't necessarily usually reach. So the only thing I can say is, again, that in some ways we're learning as we go, but I think we have a social commitment to not build more silos and find ways of being able to break down those as much as we possibly can through the use of people themselves helping find the right ways for us to be able to do that path. So some of it is actually reaching out into those communities and saying, how can you help us find ways of being able to engage the people who we would really think would benefit from participating in this. So we, again, recognizing our limitations, understanding we have to find others that have more expertise in this than us, and then being able to engage strategically in how we can use that kind of leverage to access and reduce the disparities as best we can.
This is Sara. I underscore those comments, and I think there is not a one-size-fits-all approach here because of the vast diversity in our populations. And as I said earlier, we can't just think of technology solutions, or else we will have increases in disparities. And the third, as my colleague just commented, involving community and community representatives and advisors is a critical component of this.
Thank you. And so your part two was about evaluation. We talked some about that earlier. Did we evaluating systems? Did I get it wrong?
One was disparities, the other just outcomes of efficacy of the different approaches that you're taking.
Anyone? It sounds like we're early in the process.
Yeah, we have a commitment to that. Yeah. We just, because we don't have the solutions in place, we can't evaluate them against the standard of care, if you will.
I will say that we have been running now for a number of years and actually do an ongoing analysis of it. It's not related to the return of results specifically, but it is an impact survey that goes out to users on a regular basis, new as well as people who have been in the system for a long while, assessing the benefit to the outcomes that they experience as a result of being a part of this community and the things that they use on the site and the data that's most useful for them. So we do that in an ongoing way, and then that helps us to continue to build new innovation and technology solutions based on those. But that's actually, it's called an impact survey, and it's something that's just, it's constantly going. It's never going to end. It'll be, and so as we start to do this, questions will then start being asked about the return of results for the biospecimen experience too. So.
Yeah, and in looking at the timing of the committee's meetings, one of the research projects inside the Precision Medicine Initiative that we're getting started on is we have 5 federally qualified health centers that are in the network. So Eau Claire, Wisconsin, Jackson, Mississippi, Middletown, Connecticut, San Ysidro, and Knoxville, Tennessee. We'll be doing a specific research project with those 5 FQHCs to evaluate all of the governance materials, consent, return of results, and so forth. And so I'll make a point of connecting with the committee to make sure that as we have intermediate results, we feed them to you.
Sorry, we have about 20 minutes left, so we'll start moving more quickly with our questions and answers. So again, Suzanne, Steve, Jeff, Wiley, and Kit.
Thanks. So John talked explicitly about portability of the data and the different formats and giving it back. Sally, you said that people own their data. Could you and any of the others kind of talk about the portability of the data? And then if there's time, I know, John, you thought a lot about the portability of the consent or the rights that go with the data. So if you could explicitly comment on that as well.
You know, we are still working some of this out, Suzanne. I think the portability of data, if people want the data that's currently on their profile, they can get access to that data. As we move into the biospecimen data and having that availability, we are sort of aligned with what PMI is doing, all of us is doing, and thinking about the raw data. You can have access to the raw data. We're still thinking through what the additional portability of other types of data would be, but that would be something that we would be delivering in a way that would be in the preference of the user. So I think we're not there yet. We're still trying to sort that out, and a lot of what the pilot is about right now is understanding what do people want and what forms do we need to be able to deliver that in. But I think ultimately the idea that someone should be able to have access to that data and use it in ways similar to the way John has described is really the direction we will be going in. It's just then thinking about how the mechanics and the logistics and the technical aspects of how that needs to get translated will come out. I don't know the answers to that yet.
Yeah, data portability is one of these things that is, it's an enormous focus. I worry that data portability is going to have this disparity impact because the people who are able to exploit data portability are for the most part people who are able to exploit other modern technology processes. And then the syndication of that data out into sort of the Borg system of AIs that are going to interpret this stuff is, again, restricted to a smaller group of individuals. That said, the people who are most adamant about data portability tend to be people who have a rare disease or a rare disease in their family, and so they actually have an ability to benefit from it. We tend to take the perspective that allowing raw data downloads and API transfer to those who ask for it is sort of an essential design element, that you should let people do that. Again, as part of our work inside of a larger, more diverse, more complex cohort at all of us, we're trying to understand what does it mean to offer that to a variety of populations. So it's maybe not downloading your own genome, but maybe it's being able to share it with a community member that can help you understand it. And looking at some of those elements. So I continue to think data portability is very important. I'm just trying to be wary of the actual impact it's going to have in the short term versus the long term. And in the long term, I think what people want to get to is something that looks more like e-banking, right? Where you have access to your information, and you can, if you want to use Mint or if you want to use a community-based economics program for managing your budget, you can do that. In terms of consent portability, it's something I've spent a lot of time on. I'm not entirely convinced it's possible, simply because of the way that we, from a policy perspective, create informed consent or assert that it exists. It's in the context of a study reviewed by an IRB, and that makes it quite difficult to carry that around. What I would like to get towards is where every protocol is published and every consent form is published, and we can have some sort of way of saying, does this consent form match that consent form? Have I already agreed to these terms someplace else, so that I don't get overloaded reading the same document at the same time? Because no matter how good our design is and our visual stuff, if I go through the same visual process 15 times for 15 studies, I'm going to stop seeing it by the 12th or maybe even the 3rd. And so coming up with some way to maybe do interoperability among consent forms post hoc through analysis or ex ante through using standardized terms and phrases, I think is probably more of a long-term solution than consent portability.
Thanks, Consuelo. So I've been thinking and struggling with the variety of kinds of quote data or quote results that we might be talking about. So at the one end, you have raw data, and I presume that the deal there is people get back the sort of bits and bytes that come from their data, and then they do with it what they will, but there's not a lot of interpretation or explanation around that. And then at the other end, we've got things that are either the kind of data that most people that are sort of self-interpreting or don't need a lot of explanation, or that you might sit down with somebody or get some written explanation, that we have a sense that there's an obligation not just to give you the number or the result, but to explain what it means in some way. But then there's this sort of space we haven't talked much about of, let's say, stuff that might come out of early discovery research, which I think is part of the sort of portfolio of what the committee needs to address, where there's some early hypotheses about what some biomarker-derived thing might mean, but we don't really know. It's all speculative. It's just starting to emerge, and maybe it's all a big nothing. And how do we think about that sort of data? Is that the sort of, where do we go from just saying, well, if you really want this, and you want to ask for it, you can have the raw data back, but we don't really have anything to say about it yet because we don't know what it means, to we feel obligated, or we believe the right thing to do would be to give it back with some sort of explanation. And where you make that transition from here's just the data to here's the data plus some sort of explanation, and what do you say in this very early space is one of the things I've been struggling with the most in the context of this committee's work. And I wonder if from your experience, your thoughts on that sort of class of data.
You know, one of the things that we've been looking at that very specific thing, because I think for us, and I would say that our founders would say, you know, if we have information that could be predictive of something, and yet we're still not completely certain about it, and there's some ambiguity, and someone has self-determined to be a part of our project with us and understand that there's a level of ambiguity that we're in this together to try to figure out, they would want us to find ways of being able to deliver that information in a way that could be meaningful and somewhat actionable. I'll use one example, and it's from a study that I think it was in BMJ a while back, and it was identifying certain genetic variants in people with lupus who have a predictive risk of developing nephritis as a result of the presence of that. And, you know, to not be able to share that information, even though we don't necessarily, it's not confirmatory yet, we're still sort of thinking that this group of people has the probability of developing nephritis at some point in time, is, from our perspective, an important piece of information about someone's future health. So we're grappling with this, and we're doing a lot of discussion around it, and we're gaining a lot of insights from people who would potentially be the recipients of this information to help guide us. But I think it's a conundrum that actually leaves us feeling like, well, if we have this information, we do not feel comfortable not disclosing it to people who want to receive it. So finding ways of being able to act on the self-determination of individuals who want that information is really where we're heading. But I think it's an important question that we are, as I said, continuing to grapple with, and I think that's just one small example. There's going to be others. And there will be different varying risks with that, right? So some of that information that we might have could actually be reflective of a higher risk of future health problems than, say, you know, nephritis is definitely a serious future health problem, but let's say, you know, some other, emerging variant is starting to lead us to believe that this is going to predict that you're going to have a fatal illness of some sort. That in and of itself carries so much weight, and at what point does that risk get mitigated by either sharing or not sharing, or if you do share, how do you share it? So I think these are things that we're going to continue to grapple with. You know, actually, we are fortunate to also be a part of the All of Us Technology Center, and so I think that we're working with them to think about some of these engagement and long-term strategies. So I think both Patients Like Me and All of Us actually have the opportunity to start learning together on some of this. But I think it's an important question, but I can tell you from our founders' perspective, when we have information that we believe is going to impact someone's future health, and it's important for them to get that information, we want to be sure that if someone self-determines they want it, that they get it. So.
Anyone else have?
I just one comment. I think, as I said earlier, I think that's where it becomes important. And, you know, it just underscores the importance of setting up people's expectations correctly up front in the process about what they can expect and the meaningfulness of what they can expect and not expect in terms of the results of their participation.
And I would just echo that. And one of the things I would say is I think it kind of the place where I have experience with this is returning variants of uncertain significance and asking people about their preferences for variants of uncertain significance. And certainly there are people who don't want that information, but when we present it, we could find something that we really have no idea what it means. It might be associated with something that it might not. Would you want to know this information? Many people do want to know this information. And I think for those people who want to know it, those are people who have experiences with uncertainty in their life, oftentimes uncertainty around their diagnosis or their medical circumstances or the medical circumstances of their family members. And so I think we understand what it's like to return that type of information to that type of population. I don't think and I think I've said this too many times now, I don't think we understand what other people want.
Jeff?
And this has been very helpful in sort of highlighting what we know and what we don't know, what are best practices at this point, and how much important work there is to be done in this whole domain. I wonder if you might highlight, though, whether we know anything about worst practices. Are there common pitfalls that you've seen out there that we might highlight to say, there's a variety of ways you can do this, but there's a few ways you should not do this, and that might be part of the report?
So anyone? You're not doing them, but do you know of them? Do you know of them?
Well, I think one thing that might be underscored is a worst practice, and this is obviously an easy one to highlight, is the level of language that's used to report results. If it's highly technical or it's not put in a way that people can understand it, I think that's clearly one thing that we have to avoid. We have to not speak as scientists or researchers when we're reporting these results, but we have to think about putting things in lay language that people can understand.
Anyone else?
I think I'd probably say that I think the worst thing that we can do is simply to provide people with data that doesn't have any particular meaning in the relevance to their daily life or the way that they have to think about the context of it. So the worst practices would be that we simply say, here, we're giving lots of data to you, and isn't that great? We've generated all this. Because I think that will not suffice for most people, even when they say, I just want it all, and we heard that yesterday, I just want it all, and then I'll figure out. I think there's a responsibility somewhere along the way. Worst practices would be that we don't accept the responsibility that we have to find meaningfulness in the data in some way for people who have been willing to participate, to give that information initially, should have expectations that they're going to get something back that's somewhat meaningful, or at the very least gives them some context for it. So I don't know if that answers your question, but it does feel to me like there's probably a threshold in thinking about return of results that we want to be sure that we have the capacity to do up to that threshold at the very least as the minimum viable product of the return. And then anything above that we do would be even more added substance and maybe meaningfulness. But I think there's got to be something that's at the level of a threshold that we all agree upon needs to rise to that. So
You have to click.
So, look, I come from grassroots groups working on HIV/AIDS from ACT UP, and this agitates me to no end. Don't be paternalistic and maternalistic to me and tell me what to do with my data. And you tried to deflect me by saying ownership is a complicated, there's a political economy to what you do and the way you do it. Your board is all men. Your board is highly undiverse. There are no patients on anybody's boards. And you're saying how I should get data? You're saying how I should get data? So there's a politics embedded in the way the genetic community has decided to put middlemen in charge, whether they're nonprofit or profit. And none of this panel has been from the grassroots. It's all been scientists talking about how scientists are going to tell patients what to do or what they need to do. And it agitates me to no end.
So I apologize. I'm not trying to deflect you. I'm trying to make you understand the legal underpinning to the discussion, because the policy will break if we don't have a solid legal underpinning. So I apologize for deflecting, because I'm just trying to be clear that ownership as a legal concept breaks under data. And so your point is well taken on the rest of it. But talking about ownership, it's not deflecting to address the legal reality of that phrasing in this context, I don't think.
I would just add, too, we don't have any patients specifically on our board. However, we convene a team of advisors every year. It's a cohort of about 15 patient members. They go through an application process to do that. So far, we've done it for 4 years running. And every year, we get about 1,500 applications to be a part of that board. They influence the board of directors. They actually have a voice at that. But also, anybody that doesn't get accepted into the team of advisors actually becomes part of our ambassador program. We have about 1,500 to 1,700 members on that. So they get engaged frequently. I engage with them all the time to bring a perspective. So anything I talk about anywhere, like here, has been informed by our team of advisors. I can assure you that. So,
Thank you. Wiley?
Well, my question, I think, does follow on the discussion we've just been having in a few previous questions. You had talked about evaluation, but it's pretty clear, it seems to me, that we're not entirely sure what it is we're trying to accomplish, or at least it's not clear to me in this discussion. And so what I'd like you to comment on, and how can we evaluate if we're not crystal clear about what it is we're trying to accomplish? I think also when we ask ourselves what are we trying to accomplish, we need to be thinking about this very much in context. That is something that needs to be a process or a set of processes that need to be scalable, apply across a variety of different kinds of research, and be, from a research point of view, realistic in terms of accomplishing the research. So is it possible to say, here's what our basic goal is in returning results, and therefore this is how we should evaluate any method we use? These are the objectives that we're evaluating our method against?
I would say, so when we return results, we would like to evaluate whether or not we're returning them in a manner in which the patient is being informed, and at the very least it's having a neutral effect on them. And what we would like to do is that it's having a positive effect on him, both in both a clinical and medical and social utility, that people see value to their participation in research, and they see value to the information that they've learned from research. And I think those are still difficult things to measure and to evaluate. We spent a lot of time looking at the psychological response to returning results and have seen very little signal from that. And I think there's now this push towards looking at more kind of these other types of utility type issues. And really, I think we're still developing the correct measures to evaluate that.
If I could just elaborate my question a little bit, I think your answer illustrates to me what the problem is, because we could say our objective is to provide information such that people understand, in which case we're trying to figure out if they understand the information. We could say we're trying to return the information in a way that does not create psychological distress, in which case we're trying to measure whether or not we achieve psychological distress. We could say we're trying to pass on information that people can use productively, in which case we're trying to measure what it is people do with that information. It's not clear to me whether which of those is right or whether any of them is right. I mean, it might be that all we're interested in doing is providing information in a way that people find satisfactory, whether or not it causes emotional distress, whether or not it is used or understood. It's just not, I'm proposing that we need to be thinking fairly carefully about what it is, what's the fundamental objective that we're trying to accomplish.
And so this is so well taken. So like our mission as a nonprofit comes from changing the roles in research, and in particular opening up access to the data to people who are outside the traditional research enterprise. So when we let people in our studies donate their data broadly, right back to like Greg's point, right? People have their copy, there's a copy in the study that goes to the PIs, but they can also take their data and make it broadly available for purposes outside the original protocol if they choose to. And so we judge our success based on the number of uses of that copy of the data and the demographics of the users of that copy of the data. So if that, because in a traditional study, right, we might do our Parkinson's study, it's at the University of Rochester, right, it's a very traditional study, that data sits inside the silo, right? But it's actually much easier to create an open pool of data outside that than to try to rip apart the silo structurally. So we have over 100 users of the open version of the data, which is about 70% of the participants made that donation. Those users are on every continent except Antarctica. They're high school students, they're pharmaceutical companies, they're Google, they're traditional academic researchers. And so we view that as a success because this is an example of a place where what would have been a data set available to 5 or 6 academics is now available globally under a relatively low transaction cost program, if you will, right? But that's our mission, is that. And so then there are these externalities that we try to contemplate and allow. But our specific mission is, did we change the roles of the researchers accessing and using the data in a meaningful way?
And again, just to make the point, obviously you've been very clear about that's your mission, and you've identified a metric that helps you to determine whether you're achieving your mission. That might or might not be our fundamental objective in returning results.
I'm not proposing it is. I'm saying that this is where I think you're right, which is that each of the groups that come to this are touching a different piece of the elephant. So the question is, can you anticipate externalities beyond your mission? And if so, what should those be? That might be where we could actually achieve consonance. It's probably not one reason why we do this and one way to measure it. But the question is, for each of us who come to it for different reasons, can we work towards common cause with these higher level principles?
So we are out of time, but if Sara or Sally have a quick response to Wiley's question about your objectives for return of results. You don't have to have them if you don't.
The only thing I would add would be that as we are building the layers of the kinds of results we'll be returning as a part of the pilot that we're working on with the biospecimens, we actually are asking that question: how will we know the return of this was successful? So we will know by asking, and we will know by evaluating that. So that's being built into the actual flow of the process. So.
I have no further comments.
Okay, thank you. I'll add quickly, I know of some objectives being around returning value and as well as recruitment and retention. So those are things that are being measured as the objective of returning information. Is it valuable, and does it increase recruitment and retention in a longitudinal study? So thank you all. To the panelists, we really appreciate your time and perspectives, and if I had had coffee, maybe we would have gotten speedier sooner, so thank you.
All right, my thanks too to the panel and to Consuelo for her leadership.